Imagine getting that dreaded call at 2 a.m. You pull up to the barn, tires crunching on the gravel, and the quiet night is just instantly shattered by the sound of absolute chaos. You walk in, and there's a horse violently rolling, sweating profusely, scrambling up, only to crash right back down to the ground. In equine practice, this is pretty much a guarantee, and it's one of the most terrifying emergencies you'll ever face. So in this explainer, we're going to master the high-stakes framework of deciding if what you're looking at is just a bad case of gas or a true life-threatening surgical emergency. The owner is usually standing right there, right? Absolute panic in their eyes, asking you, "Hey doc, is it just a bellyache?" But in your head, the real question you have to answer, and answer fast, is way more severe. You need to figure out, can this horse wait? Or is every single passing minute actively costing this animal its intestine? Because with these gut emergencies, the clock isn't just ticking, it is literally destroying tissue. If you miss this call, it doesn't just mean a longer sleepless night for you. It could easily cost the horse its life. Okay, here's our roadmap for today. We're going to cover the anatomy of equine colic, the 3 Ps framework, mild versus severe cases, the systematic field workup, and finally, those critical surgical red flags. Let's kick things off with part 1, the anatomy of equine colic. To really grasp the stakes here, we have to talk about the unique and frankly unforgiving design of the equine digestive tract. Horses have this massive, incredibly complex GI tract, but it comes with one major design flaw. Unlike dogs, cats, or us, horses physically cannot vomit. Their anatomy literally prevents it. They have this incredibly tight cardiac sphincter valve, and the angle where the esophagus meets the stomach acts like a one-way trapdoor. So what does that mean? It means any gas, fluid, or feed has a one-way ticket. It can only go forward. If there's a roadblock downstream, there is zero pressure relief valve. The pressure just builds and builds and builds inside that abdomen, like a balloon about to pop. Here is how that internal disaster snowballs. Step 1 is usually pretty simple, just a basic gas buildup or a mild feed impaction, kind of like a traffic jam in the gut. Often, you can just manage those medically. But if it doesn't resolve, we get to step 3, a displacement. This is where the sheer weight of all that trapped gas and fluid literally forces the large intestine to migrate out of its normal anatomical spot. And if that keeps going, we hit the absolute nightmare scenario, step 4, a fatal twist or volvulus. The intestine completely rotates on its own axis, twists tightly, and completely chokes off its own blood supply. Moving right along to section 2, the 3 Ps framework. Now that we know the mechanical why, we need a solid mental model for when you're actually standing in that dark stall trying to figure out what's happening inside. That's where the 3 Ps come in. As the blockage sits there, the first P, pressure, shoots up inside the gut. That massive pressure pushes out against the intestinal walls, which causes the second P, perfusion, or blood supply, to absolutely plummet. The tiny capillaries just get squeezed completely shut. Without that oxygen-rich blood, the cells start dying, and that tissue death leads directly to our third P, excruciating pain. It's a brutal, simple equation. More pressure equals worse perfusion, which equals greater pain. All right, section 3, mild versus severe colic. With those 3 Ps in our head, we have to train our eyes to spot the pattern instantly. Because colic isn't just one symptom, it's a whole picture. And the contrast here is night and day. A mild, medical colic, the horse might just be quietly pawing the ground, maybe glancing back at their flank, lying down occasionally. Their heart rate is pretty stable, and they respond great to a basic dose of pain meds. But a severe surgical case, that horse is throwing itself around so violently it's legitimately dangerous for you to be in the stall. They're dripping sweat, their eyes are panicked, their abdomen is completely silent when you listen, and your strongest painkillers do absolutely nothing to touch the pain. But I want you to remember this because it's absolutely vital. The ultimate warning sign isn't necessarily how bad the pain looks the second you arrive. The real test is whether that violent pain comes roaring back the minute your analgesics wear off. Say you give a strong painkiller, the horse gets up, shakes off, looks totally fine. But 30 minutes later, they're thrashing on the ground again. You are almost certainly dealing with an ischemic gut. The blood supply has been choked off. That returning pain is literally the intestinal tissue screaming for oxygen as it dies. Let's get into section 4, the systematic field workup. So how do we actually prove what's going on? You can't just guess, right? Especially when you're stressed, tired, and dodging a 1,000-pound thrashing animal in a dim barn. You need a rock-solid, step-by-step system to anchor you. Experienced vets build their clinical puzzle using these 5 specific actions.
checking the heart rate, listening for gut sounds, doing a rectal exam, passing a nasogastric tube, and if you have the gear, ultrasound or fluid analysis. Gathering these pieces is what definitively tells you if surgery is the only option left.
First step in the workup is the heart rate. Normally, an adult horse is sitting at a cool 28 to 44 beats per minute. A persistently elevated heart rate is essentially a screaming siren that you cannot ignore. It's a direct reflection of pain, stress, and shock. Now, you don't look at it in a total vacuum, but if you're repeatedly getting a heart rate over 60 or pushing up into the 80s, that is a massive red flag that something inside that belly is going terribly wrong and it's escalating fast. Next, we listen and we feel. An eerily silent abdomen when you use your stethoscope means normal gut motility has just shut down completely. And then you combine that silence with what you find on a rectal exam, you're not just looking for manure in there, you're feeling for architectural changes. If you reach in and feel bowels that are rigid and gas distended, literally feeling like a totally overinflated basketball, or you feel organs that have shifted into the wrong quadrants, well, the picture gets pretty terrifying. Finding that instantly shifts your plan from let's wait and see to we need to act right now. After that, we pass a nasogastric tube. This does two huge things. First, it vents that dangerous gastric pressure we talked about, which keeps the stomach from literally rupturing. But diagnostically, it is a goldmine. If you pass that tube and instantly get liters upon liters of foul-smelling fluid pouring back out, that heavily points to a severe small intestine obstruction. Because it can't move forward, all that fluid just backs up into the stomach. Buckets of reflux is a massive surgical warning sign. Which brings us to our final section, the surgical red flags. We've gathered all our evidence. We've checked the heart, the gut, felt for displacement, and checked for reflux. Now it is time to make the call. Look, no single test independently decides surgery. But when you start seeing this checklist of red flags bunching together, a heart rate that will drop, pain that viciously breaks right through your meds, gallons of toxic reflux, tightly distended loops on your rectal exam, when you see all of that together, waiting is just not an option anymore. The horse doesn't need more painkillers. It needs a surgeon immediately. Actually, let's put on our board exam hats for a second. This is a classic scenario you'll see on the BCSE or NAVLE. If a horse gets pain meds and improves for a bit, but is violently throwing itself on the ground just 30 minutes later, what do? Think back to the 3 Ps and what that returning pain really means. Take a second. What's your very next step? The only correct answer, both on a test and out there in a muddy paddock, is immediate referral for a surgical evaluation. Because that specific clinical pattern strongly suggests an ischemic lesion. The blood supply is entirely cut off, the tissue is actively dying, and trust me, no amount of magic field medicine is going to untwist that intestine. It requires physical, surgical correction to save the animal's life. So, to wrap this explainer up, I really want you to burn these 3 non-negotiable indicators into your brain. 1. A persistently elevated heart rate, especially climbing up over 60. 2. Significant reflux just pouring from the nasogastric tube. And 3. Severe, violent pain that absolutely refuses to quit, even with heavy meds. Those 3 things are your beacons in the dark. Because the reality is, equine emergencies are going to happen. You are going to see colic. Recognizing a simple bellyache, that's the easy part. The real challenge, and what makes a truly great practitioner, is recognizing the horse that simply cannot afford to wait. So the next time you find yourself standing in a freezing stall at 2 a.m. with a horse in absolute agony, will you be ready to trust your framework, look at the evidence, and make the call that saves a life?